Okay, so good morning, everyone. I'm David Miller. I'm a senior public health officer at Birmingham City Council. I'm one of the leads for NHS Health Checks, hence delivering this webinar today. So thank you very much for being here. We're scheduled for an hour, but some of you might be relieved to hear we won't need all that time. I'm sure you're all very busy. So yeah, let's make a start. So NHS Health Checks as part of the Birmingham Measurement Tools webinar series. First of all, a little bit of introduction. With any intervention, it's really key that impact and outcome measurements are a part of this. What that does is allows us to demonstrate that the intervention that's being delivered is having a difference, which is obviously something every intervention should have clear aims about what it's trying to do, and we need to kind of make sure that we can benchmark that and see what's being achieved for Birmingham citizens. Using standard tools allows us to compare different interventions impacts. This is also really important because if combined with standard measures for people's identity, we can work out and use the data to assess who these interventions are most effective for. We're very aware that certain communities are at higher risk of certain health conditions, and therefore require an additional focus from us to try and address these inequalities. Also, just to say that I'm just going to move, sorry, the screen has it in a way that I can't see all the slide, but I've moved it now. Okay, and it's also really important in terms of funding for interventions. Whether that be Birmingham City Council or other organisations that are funding interventions, it's really, really important that the approach that's being used can be justified. This can justify both continued use of this type of intervention or potentially scaling up an intervention. Okay, so the public health measurement toolbox, I'm aware that some of you might actually already have attended sessions this week, so might know a little bit about this already, so I won't go on about it for too long. It's been developed to standardise impact and outcome measures for interventions that are trying to improve health and wellbeing across Birmingham. So it's been developed recently and it's specific for Birmingham, so it's to some extent a bespoke toolbox. Its intention is to support organisations when they are developing projects to build the appropriate measures into their service design. In the past that we've seen that different projects have varying kind of levels in terms of how good their measures are in terms of measuring impact. So this is a way to kind of make sure that they're all reaching a certain standard, really. It's also intended to provide clarity and transparency on how to clearly assess and measure interventions based on their focus, which can, as I've said before, be demonstrated clearly when applying for funding. It's just so important that any funding has a demonstrable impact on health in this context. It also allows for accurate and meaningful comparisons between different programs and interventions to help inform decision making, which is also really key. We've got the contents here. As it says, the toolbox is a developing set of resources to support measurement related to different areas of health and well-being. And there's a list there, physical activity, smoking, mental well-being, and so on. There's also for each section a description of the issue, links for local or national information, a description of the tool, information on any registration requirements, useful links to support behaviour change, and a case study example of using the tool in practice. Okay, so on to the specific NHS Health Checks toolkit. First of all, for those of you who don't know, I'll provide a little bit of background for what an NHS Health Check is. The NHS Health Check is a free NHS health assessment funded by the council and undertaken by GPs and pharmacists for people aged 40 to 74 years once every 5 years. I would just say that currently in Birmingham we don't have pharmacists delivering NHS health checks, but it is something that we're looking to introduce in future. Also, in terms of those people who receive health checks between 40 and 74, there are some criteria in place in terms of them not having certain pre-existing health conditions, because they should be monitored regularly anyway without having to need a health check for this. The NHS Health Check aims to find undiagnosed disease early and give patients space and time to talk about risk factors like inactivity, smoking, and also any concerns about issues like dementia. This next bullet point just gives you an idea of the sort of scale that we operate at in terms of Birmingham with NHS Health Checks. In 22-23, about 90,000 people were invited for an NHS Health Check in Birmingham, but only about 31,000 people took up the offer from their GP practice. So we're obviously keen in future to push up that number of people who are actually taking up the offer and receiving NHS Health Checks. It's also worth noting that uptake in general is lower in men and in some ethnic communities. So a little bit of national and local context. Birmingham has a very diverse population, much more diverse than England as a whole, with over 50% of citizens from minority ethnic backgrounds. That combined with the fact that there's significant deprivation, with 88% of Birmingham's wards more deprived than the England average. Um, uh, that presents a significant challenge in terms of health inequalities, because both, certain ethnicities are more susceptible to certain health conditions, and also we're well aware that people who live in deprivation are much more susceptible to certain health inequalities and risk factors. So by delivering more NHS health checks, that's one of the ways in which we can actually tackle these health inequalities. High risk groups for diabetes is something I've noted here. This is just as an example, because obviously there's a number of things that are screened through NHS health checks. But as an example for diabetes, we have data that shows, and there's evidence that's been around for quite a while now, so it's very well established that African, Caribbean, and South Asian communities are at higher risk for diabetes. So that's one of the reasons we're really keen to improve uptake for NHS health checks for these communities. What are we aiming to measure in the tool? So with this NHS health checks tool specifically, we're aiming to measure awareness of the programme and also ultimately increase uptake. And as I've just said, particularly for African, Caribbean, Pakistani, Indian or Bangladeshi communities. And also as well as awareness, we're keen to improve uptake, and we know that if this is increased, we're likely to be successfully contributing to our efforts to tackle health inequalities in Birmingham. Okay, so the measurement tool. It's in the form of a questionnaire. There will be a web link for it, and the following questions are on it. Did you know about the NHS Health? Do you know about the NHS Health Check programme? When did you last get an invitation from your GP for an NHS Health Check? Have you had an NHS Health Check in the last 5 years? Do you want to have an NHS Health Check? And if no, why don't you want to have a health check? So these are all really key for us to kind of understand a little bit more of the context and the data around health checks for people who are service users for interventions. There's no cost associated with it. It'll be a self-completed questionnaire, and in terms of frequency, so that we can see progress through the intervention, we're asking for this to be completed pre-intervention, post-intervention, and also 6 weeks post-intervention. As I've said, our ambition really through this is to increase the number of eligible adults who have received an NHS health check in the last 5 years. There's also a link at the bottom there to some benchmark data both the Birmingham City Observatory and OHID, which is the Office for Health Improvement and Disparities fingertips dashboard. I think these slides will be shared, so you will be able to access those links later. Using the tool, it's really important that the questions aren't modified in any way. This is key for what I was referring to earlier about the need for it to be standardised and enable comparison across different interventions that are being funded. There are different ways of asking the question, and we're trusting providers to kind of use what's most appropriate at each time. So one of the ways is clearly face-to-face with someone asking the citizen out loud the question. This is probably most appropriate when you've got someone who's going to, you're aware there's going to need additional support or help with answering questions. For example, if you're working with people who have a learning disability or other disabilities for that matter. Uh, so the downside of this approach is that it can be overheard, and therefore you need to think about confidentiality of the setting and environment, and it will also require inputting by the person asking the question onto the data collection system. The other way listed here is a self-completed questionnaire on paper or digitally. This is obviously quicker to collect and is probably easier to standardise and report. However, the downside for this is that if an individual has questions about it, they won't necessarily have access to you as easily to give those questions. And also, if it's done digitally, that relies on them having digital access. We're very aware that we don't want people being digitally excluded in any way during this process. Sorry, my laptop's just being a bit slow this morning to let me go through each slide. Onto the next one, I mean. So specific risk and issues to consider. To increase rates of questionnaire completion, providers should explain to users how their data will be used and why it is important. From an individual and public health perspective, if possible. In terms of the individual, I think that's just making sure that they understand that you as a provider can be trusted with their data. And then also from a public health perspective, that's kind of providing a little bit of context of why ultimately completing this questionnaire is going to improve health outcomes for people. And you just need to frame that really positively, I think. We also need to promote digital inclusion. I touched on this just a second ago. If possible, providers should do what they can to support users, because clearly not all users will have smartphones or internet access, whatever they might need to complete the questionnaire. Lastly, if there are language issues, support should be given where possible. It might be very difficult in some situations, but one of the ways might be seeing if someone else in the team delivering the intervention is able to speak that language, or potentially using software such as Google Translate. So how to report the findings. Providers need to ensure that questions are the same as the toolkit. As I said, that's really key for providing a comparison. Providers should collate the results for each value to give a clear understanding of intervention demographics. Also really key, especially so we understand what's needed for different communities and what the impact is for different communities. Providers should state the values given for any participants who answered other. And then lastly, in cases of small sample size, small number suppression should be used to keep results confidential. So this means if less than 5 people gave the same answer to you, you don't report this in the public report, and you just report less than 5 as the answer. That's really important, because otherwise there's a risk of to the person being anonymous, which is obviously something in terms of data protection we're conscious of. Yeah, I do apologise about how slow it is for me to change slides today. Okay, so lastly, I've got a case study here. So just to give you a little bit of an idea of the kind of intervention that that would be required in future to use the toolkit. So we could have a walking group for older adults that's set up in Birmingham to increase physical activity levels and social capital, meaning reducing loneliness essentially and making sure people have more connections, delivered over a defined period, 12 weeks, for example. Um, so in an intervention like this, we'd expect there to be quite likely to be quite a few people that are eligible for NHS health checks, and therefore it would be appropriate to use the toolkit. Here we've just got a few additional resources. So yeah, I think have a look at them if there's interest. I think they're all really good resources and pretty useful. So we've got them there for you.